Um, what if a surgery to, remove one organ caused the physical structure of a completely different part of your body to just change overnight?
Yeah, it sounds crazy, right? But it happens.
It really does. Today, we're looking at this biological domino effect that, honestly, medicine rarely warns women about. Welcome to the deep dive.
Good to be here.
We're taking a stack of medical sources today. We've got clinical guidelines from the British Menopause Society, the NHS, the American Urological Association, and some specialized women's health clinics.
All right, some really heavy hitters.
Exactly. And we're zeroing in on one highly specific, but often totally silent struggle. So our mission today is to answer one critical question. Can low estrogen after an oophorectomy actually cause or drastically worsen the physical feeling of vaginal laxity?
And, it's a question that fundamentally changes how we understand female anatomy and post-operative recovery, too.
Right.
So whether you're listening to this because you're prepping for your own medical consultation or you're supporting a loved one, or maybe you just want to understand the profound interconnectedness of the human body, this shift in perspective is absolutely vital. We're exploring how an abrupt change in hormones doesn't just cause hot flashes. It literally alters the microscopic architecture of your tissues.
Okay, let's unpack this terminology first, just so we're all on the same page. An oophorectomy is the surgical removal of the ovaries, right?
Exactly, yes.
And a patient might have this done for cancer prevention, especially with genetic stuff like BRCA mutations. Or it's used to treat severe endometriosis, or sometimes it's performed alongside a hysterectomy.
Right. It's incredibly common in those scenarios.
And on paper, it looks like this really localized structural removal. Like you take the organ out, you close up, and that's it. But looking at the data from these clinics, the systemic shock is just immense.
Oh, it's massive.
Yeah. To understand why this specific surgery affects a feeling of laxity or looseness in the pelvic region, we have to grasp how surgical menopause differs biologically from, like, natural menopause.
Because they're entirely different physiological events. I mean, totally different. In natural menopause, the body goes through this highly gradual transition. According to the guidelines we looked at, the ovaries slowly decrease their hormone production over an average of, 2 to 5 years?
Yeah, and the sources even point out that for about 10% of women, that gradual process lasts for more than 15 years.
Right. The body has this really long runway to just adjust to the new hormonal landscape.
It's kind of like a dimmer switch on a light,
Yeah.
just slowly turning down the room.
That's a perfect way to put it, yes.
But an oophorectomy is not a dimmer switch. It's like taking a pair of scissors and just cutting the power cord.
Exactly. The hormone supply just completely stops.
So if the systemic withdrawal happens that fast, where does that shock hit the hardest? Because, I wouldn't immediately think of vaginal tissue.
Well, if we connect this to the bigger picture, we really have to stop thinking of the ovaries strictly as reproductive organs.
Oh, right. Because they do a lot more than that.
Exactly. I mean, they do release eggs, sure, but they are also continuous hardworking factories. They're pumping out a massive supply of estrogen, progesterone, and testosterone for the entire body.
Wow.
So when they're surgically removed, that transition period just vanishes. The abruptness of that loss is it's physiological and deeply systemic. The chemical messengers that tell the rest of the body how to function are just suddenly absent.
Which makes sense why the clinical data is so intense. I was genuinely shocked by how fast this happens. Because the drop is a cliff edge, right, rather than a gentle slope. The symptoms hit with an intensity that natural menopause rarely produces.
Yeah, the medical consensus is very clear on this. For women who have this surgery before the age of 45, the sudden withdrawal of hormones, if they don't treat it with hormone replacement therapy, it triggers severe hot flashes, anxiety, and it significantly increases long-term risks for osteoporosis and cardiovascular disease.
That is just so intense.
It is. And crucial to our question today, it causes profound and rapid changes to pelvic and vaginal health.
Okay, so let's follow that domino effect down to the pelvis, because I think there's this common assumption that the vagina is just like static tissue. But the sources describe this incredibly active microscopic world down there that relies heavily on estrogen.
Oh, it's a bustling microscopic ecosystem. Estrogen receptors are concentrated heavily all throughout the pelvic region. You find them in the vagina, the urethra, the bladder,
Oh,
trachea.
the trigo, what is that?
It's the smooth triangular region at the base of the bladder.
Oh, okay. Got it.
Yeah, and they're woven all throughout the pelvic floor muscles, too. In a healthy, estrogen-rich environment, vaginal tissue is highly dynamic. The outermost layer of cells, which are the superficial epithelial cells, they are constantly regenerating.
Right.
Under the influence of estrogen, those cells shed and replace themselves literally every few hours.
Every few hours. Wait, really? That seems incredibly fast for tissue regeneration. Like, why is the body burning so much energy to turn over those cells?
Because it serves a really vital protective purpose.
Hmm.
As those superficial cells die and shed, they release a sugar called glycogen.
Okay.
And that glycogen acts as a food source for the good, healthy bacteria in the vagina, specifically lactobacilli.
So the body is intentionally feeding its own microbiome. That's amazing.
It's brilliant. And in return, the lactobacilli eat the glycogen and they produce lactic acid. That lactic acid maintains the vaginal environment at a nicely acidic pH, usually around 4.5 or even lower.
Right, which keeps things clean.
Exactly. That acidic environment is the ultimate defense mechanism. It keeps bad bacteria and infections completely at bay.
Okay, so here's where it gets really interesting. Because beyond managing the surface bacteria, estrogen is also working deep within the tissue, right?
Yes. Below the surface layer, estrogen interacts with cells called fibroblasts. And these fibroblasts are the manufacturing centers for collagen and elastin.
The stuff that keeps things bouncy and stretchy.
Precisely. As long as estrogen is present, the fibroblasts continuously pump out collagen. That ensures the vaginal tissue remains thick, highly elastic, and filled with these healthy accordion-like folds called verrugae.
Okay, wait. This is where I need to clarify something.
Sure.
If the estrogen is suddenly cut off overnight because of the surgery, the power cord is snipped,
Yeah.
what actually happens to those fibroblasts? Do they just give up and disappear?
They don't disappear, no, but they enter a state of forced dormancy.
Oh, wow.
Yeah, the medical term is they transition into fibrocytes. Without estrogen binding to their receptors to, signal them to work, they essentially go to sleep. The production of fresh collagen and elastin just grinds to a halt.
So the whole factory shuts down.
Exactly. And the existing collagen fibers in the tissue begin to hyalinize, meaning they fuse together and they become really stiff.
Wow. So the tissue loses its stretch and bounce because the collagen factories are asleep.
Yeah, and the entire mucosal layer thins out dramatically as a result. The thinning causes the loss of the rugae, so those deep elastic folds we talked about, they just smooth out.
That sounds uncomfortable.
It is. And remember the cell turnover we discussed? The rapid shedding that releases glycogen?
Right, the stuff feeding the good bacteria.
It's exactly. That drops off a cliff. Without glycogen, the lactobacilli starve. The lactic acid disappears. So the pH of the vagina rises above 5, becoming way more alkaline.
And I'm guessing bad bacteria love that.
They do. This new alkaline environment invites bad bacteria like E. coli to colonize. That leads to recurrent urinary tract infections and abnormal discharge.
It's just a complete structural and chemical collapse of the ecosystem.
It really is. And the visual and physical changes are striking, too. The tissue becomes pale, it loses its natural moisture, and it becomes what doctors call friable.
Friable?
Yeah, friable tissue is so fragile that it can tear and bleed easily, especially during physical activity or intimacy. And this whole cascading chain reaction of thinning, drying, and inflammation, it has an official medical diagnosis. It's called genitourinary syndrome of menopause, or GSM.
Okay, I want to pause on GSM for a second. Because reading through the gynecology sources, I kept getting tripped up by a major point of confusion.
Oh, what's that?
Well, I always thought vaginal laxity and pelvic organ prolapse were essentially the same thing. I just assumed laxity meant the pelvic floor muscles had collapsed. But the literature treats them very differently. Why is that?
Yeah, that's a really common misconception. Pulling those two concepts apart is absolutely vital because they require totally different medical approaches.
Okay.
Pelvic organ prolapse is an anatomical, physically measurable descent of the pelvic organs. The bladder, the uterus, or the rectum literally drop down into the vaginal canal.
Because the support failed.
Right, the supporting ligaments and muscles have failed or severely weakened. A doctor can use imaging or an exam to actually measure the descent of a prolapse in millimeters.
Okay, so prolapse sounds like a structural collapse, like the roof of a house caving in. It's measurable. What is laxity then? Are women just confusing the two?
No, they aren't confused at all. They're just describing something different. Vaginal laxity is defined in the medical literature as a subjective sensation.
Subjective.
Yes, it is the patient's lived experience of looseness. It's a lack of grip, a feeling of being less supported, or experiencing significantly reduced friction during intimacy. There's no blood test or scan that can quantify the sensation of laxity.
Oh, so if prolapse is like the roof of the house actually caving in, laxity is more like the wallpaper is just losing its grip on the wall.
Yes, that is a perfect way to visualize it.
Which brings us to the core mission of our deep dive today. Does the low estrogen after an oophorectomy drastically worsen laxity symptoms? If the roof isn't caving in, why does the patient feel so loose and unsupported?
Yes, low estrogen drastically worsens the sensation of laxity, but the mechanism is it's kind of counterintuitive. Because it's not necessarily because the pelvic floor muscles have suddenly failed or become weak overnight, the sensation is caused by the tissue itself, the lining of the vagina.
The wallpaper.
Exactly. Because that mucosal lining has thinned out, dried up, and lost its elastic collagen due to the sudden onset of GSM, it fundamentally changes how the area feels.
Right, so the starring wallpaper on top of the muscle is the real culprit here.
Exactly. Because the tissue is thin, smooth, and inelastic, it provides far less friction. It feels unsupported. For the patient, the physical sensation registers as looseness or laxity. The root cause is actually poor tissue quality driven by estrogen starvation, not necessarily a muscular deficit at all.
Wow, it's a tissue problem disguised as a muscle problem.
You're exactly right.
So what does this all mean for treatment? If a woman feels this distressing laxity after her surgery and talks to her doctor, what's the protocol? I mean, the common advice you always hear is to just do like a million Kegel exercises to try and tighten everything back up. Does that actually work?
Well, what's fascinating here is that while pelvic floor muscle training like Kegels is fantastic for overall pelvic health, and it's a primary treatment for actual prolapse,
Right.
you simply cannot flex a tissue problem away.
Wow. Yeah, that makes sense.
You could build the strongest pelvic floor muscles in the world, but if the mucosal lining covering those muscles remains paper-thin, dry, and entirely lacking in collagen, the patient is still going to experience that distressing sensation of laxity and friction loss.
Because you're working the muscle underneath, but completely ignoring the starving tissue on top.
Precisely. So the clinical guidelines from the British Menopause Society and the NHS emphasize that the gold standard treatment for this specific type of GSM-induced laxity is local vaginal estrogen.
Local, meaning not a pill you swallow.
Right. We are talking about highly specific localized doses delivered straight to the starving tissue. It's usually prescribed as estradiol pessaries, estriol creams, or a vaginal ring.
Because it's localized, it's not circulating through the whole bloodstream the way a traditional oral hormone replacement pill or like a systemic patch would.
Exactly. By applying a tiny amount of estrogen directly to the tissue, it bypasses the rest of the body almost entirely. The hormone is applied exactly where those estrogen receptors are clustered.
And the response is pretty fast, right?
The clinical response to this targeted delivery is generally rapid and sustained, yeah.
So what is actually happening at the cellular level when you introduce that local estrogen? Do those dormant fibroblasts actually like wake back up?
They do. It's literally like turning the power back on in the factory. The local estrogen binds to the receptors, it wakes up the fibrocytes, and it induces a process called neocollagenesis.
Which is making new collagen.
Right, the formation of brand new, healthy collagen. This fresh collagen thickens the vaginal epithelium, it brings back the rugae, restoring those elastic folds.
It essentially reboots the entire microscopic ecosystem we talked about earlier.
It does. The cellular shedding restarts, which brings back the glycogen. Then the lactobacilli feed on the glycogen, produce lactic acid, and that drops the pH back down to healthy acidic levels.
Clearing out all the bad bacteria in the process.
Exactly. So by restoring the natural lubrication, the plumpness, and the thickness of the tissue, local estrogen frequently just completely resolves the worry and sensation of laxity. And it does this without mechanically or surgically tightening a single muscle.
That is incredible. And there's a statistic in the sources regarding the safety and dosage of this treatment that genuinely surprised me.
Oh, the oral pill comparison.
Yes. The sources note that using standard local vaginal estrogen twice a week for an entire year delivers roughly the same amount of estrogen to your body as taking just one single 1 milligram pill of oral HRT.
It's wild, isn't it? The dose is incredibly low. And because it's so localized, it's considered safe for the vast majority of women. That often includes those who have medical contraindications that prevent them from taking systemic hormone replacement therapy.
That context is incredibly reassuring, I think. But I do want to make sure we cover all the bases here.
Of course.
The clinical guidelines also highlight non-hormonal options for anyone who absolutely cannot or just prefers not to use any form of estrogen. And there's a really fascinating piece of chemistry hidden in the guidelines about over-the-counter moisturizers and lubricants.
Oh, yes, the osmolality.
Right, osmolality. I was reading about it, but I need you to translate the science here.
Yeah, it's something very few people know to look for on a label. Osmolality is essentially a measurement of the concentration of particles, so things like salts, sugars, and preservatives, within a gel or a cream.
Okay.
The World Health Organization strictly recommends that vaginal lubricants have an osmolality of under 1,200 milliosmoles per kilogram. But ideally, they should sit right around normal human physiological levels, which is between 260 and 290.
Why does that concentration matter so much if you're just trying to moisturize the area?
Well, think about being stranded at sea and drinking ocean water.
Oh, bad idea.
Right, terrible idea. The salt water is so heavily concentrated that it actually pulls the existing hydration out of your body's cells just to balance the salt. You end up far more dehydrated than you started.
Wow.
The exact same principle of osmosis applies here. If you apply a highly concentrated, hyperosmolar product into a vagina that is already suffering from dry, fragile GSM tissue, that heavy concentration draws water out of the vaginal cells.
Oh my gosh. So putting the wrong, highly concentrated gel into the area actually dehydrates the exact tissue you're trying to moisturize.
Yes. It actually accelerates cellular damage and irritation. So if a patient is utilizing non-hormonal moisturizers to hydrate the tissue or using lubricants for intimacy,
Yep.
they really have to verify the products are properly pH balanced around 4.5 and isoosmolar.
Isoosmolar meaning it matches the body.
Exactly. An isoosmolar product matches the body's natural concentration, ensuring it hydrates the cells rather than damaging them further.
That is such a crucial detail. It really highlights how careful you have to be and how specific the science of this pelvic ecosystem really is.
Absolutely.
So, just tracing our journey today. An oophorectomy causes an immediate overnight shutdown of estrogen. This rapid systemic loss forces those collagen-producing cells into dormancy, and it drastically alters the physical architecture of the vaginal tissue.
Right, the domino effect.
And then this thinning, drying tissue change creates a very real, very distressing physical sensation of laxity or looseness. But the hopeful takeaway here is that this sensation can be beautifully managed.
It really can.
By using localized estrogen or specialized isoosmolar moisturizers, you can wake those tissues back up and restore the ecosystem.
It is a completely manageable condition once the biology behind the sensation is understood. But, I want to leave you with one final, slightly provocative thought to mull over regarding these surgeries.
Oh, please do.
Throughout this entire deep dive, we've talked extensively about the loss of estrogen and its structural impact on the tissues. But remember earlier when we discussed how the ovaries function as factories?
Right, they make more than just estrogen.
Exactly. They don't just produce estrogen and progesterone. They are a primary source of a woman's testosterone.
Which is a hormone society usually just associates with men and like building muscle.
Right, but it is absolutely vital for female health. After a surgical menopause, that sudden drop in testosterone is dramatic. Yet, in standard postoperative care, evaluating and replacing that testosterone is almost entirely ignored.
Ignored entirely.
Yeah, and evidence shows that a profound drop in testosterone deeply affects a woman's overall vitality, her baseline energy levels, her muscle strength, and her sexual desire.
So it's just left out of the recovery conversation entirely, even though it dictates so much of her quality of life.
Exactly. It raises a really vital question for you to explore on your own. In our modern medical pursuit of treating the physical symptoms of aging and surgery, how much of female vitality and joy is left completely unaddressed simply because patients don't know they're allowed to ask about it?
That is a powerful question. And it brings us right back to where we started today. We aren't just machines with interchangeable parts, We are complex ecosystems. And if you or someone you love is navigating this, you deserve care that looks at the whole landscape, not just the single piece that was removed.